indicate whether the GFR will tend to rise or fall, that should be or, in response to an increase in each of the following. So the glomerular filtration pressure, that's the first one. So basically we're being asked to decide whether or not these factors will favor filtration or whether it will oppose filtration. Because remember, if it's going to favor filtration, the GFR will rise. If it's not, the GFR will fall, okay? So the first one is the glomerular filtration pressure rises, and we know that because the glomerular filtration pressure is favoring filtration, right? It's the force that's moving plasma from the glomerulus across to the Bowman space. And so if that rises, GFR will tend to rise. The second is the glomerular capillary hydrostatic pressure. So this is that push force from the glomerular capillaries. And if that rises, that will also favor glomerular filtration pressure rising, which will favor GFR rising as well. Okay, and that was one of the Starling forces. The third one is if the glomerular capillary osmotic pressure rises. And now the glomerular capillary osmotic pressure is a pull force from the capillaries, right? Glomerular capillary osmotic. And so if that rises, that's going to be opposing filtration, right? Think about the direction of movement of plasma. If I increase my glomerular capillary osmotic pressure, I'm going to be increasing the force that's pulling fluid back into the capillaries. And so that's going to be opposing filtration. And so GFR will tend to fall, okay? The fourth one, if the hydrostatic Bowman's capsule pressure rises, so think about where this pressure is. It's in the Bowman space and it's hydrostatic, so it's pushing. This is going to be a push force, again, pushing from the Bowman's capsule back into the glomerular capillaries. And so that too will favor, oppose filtration. And so that will cause GFR to fall. And then lastly, the concentration of proteins in the plasma. So if the concentration of proteins in plasma rises, we should be equating that to the osmotic pressure, the glomerular capillary osmotic pressure, right? More proteins means more of an osmotic pressure in the capillaries, right? Because it's saying the proteins in the plasma. And so if that rises, that is going to be a force that is opposing filtration, because again, that's a pull force that's pulling from the Bowman space back into the glomerular capillary. Okay, so that will cause GFR to fall. So the first two will cause a rise in GFR, and the last three will cause a fall in GFR. Okay, and I really want you to make sure that you understand why each of those was so, and that you got it correctly, or that you understand why you didn't get it correctly. Alrighty. Okay, number two, name the three intrinsic control mechanisms that regulate the GFR, and then briefly explain how these mechanisms work to keep GFR constant in the face of changes in the mean arterial pressure. So we spoke about these three mechanisms, and we talked about that graph where for the window of a mean arterial pressure between 80 and 180, the GFR stayed the same at 125. And so we're asking here, what are the three mechanisms that ensured that the GFR stayed the same between that window of 80 to 180? And so we described the myogenic regulation, so this mechanism here on the left. This was the stretch in the smooth muscles of the arteriole, of the afferent arteriole. And so if they stretched, the response was to constrict or to increase the resistance. The second mechanism was the tubular-glomerular feedback. And this was the macula densa cells that secrete paracrine factors that would communicate to the smooth muscle cells and allow them to constrict if there was stretch in the distal part of the tubule. So if there was increased flow coming through the distal parts of the tubule and there was increased stretch, the paracrine factors would communicate to the smooth muscle cells and allow them to constrict to resist that change in GFR. And then the third mechanism was the mesangial cells. So the mesangial cells are these strips of smooth muscle located around the glomerulus. And if there was increased stretch, they would constrict in order to regulate that GFR and keep it constant. Okay, so those are the three intrinsic mechanisms we talked about. And then the last question is the control of afferent and efferent arteriolar resistance by renal sympathetic neurons an example of intrinsic control or extrinsic control? Why? How does an increase in sympathetic tend to affect the GFR? So if we're controlling the size of the afferent and efferent arteriole via sympathetic neurons, this is a form of extrinsic control, right? The intrinsic mechanisms are things that the kidneys are doing within themselves. So the macular denser cells are within the kidney, the arterial smooth muscles within the kidney, the mesangial cells within the kidney. Extrinsic mechanisms are things that are happening outside of the kidney that are influencing the arterial resistance, right? So if we're talking about neurons or hormones, this is a mechanism of extrinsic control. And so if you go back to this flow chart, we saw that an increase in sympathetic activity is going to increase the resistance, and that would decrease the GFR. Alrighty, so sympathetic affects GFR by decreasing it. Okay, let me see if there are any questions that may have been raised from those checkpoint questions. Okay, I don't see anything, so let's go ahead and try to make sure you're writing down the responses to these checkpoint questions. It's really going to help you make sure that you're getting all of these concepts and being able to connect them as we go along. Okay, so I think we got to this slide, I want to say. So we just began speaking about reabsorption in the tubules. And so we're talking about, excuse me, what happens in the proximal tubule. So this is the first part of the tubular structures. And we're really describing how reabsorption takes place here. Now, before we get into the actual mechanism, I want to remind you that when we're speaking about the proximal tubule, reabsorption here is unregulated. It is not, it's happening independent of any external factors. It's happening independent of hydration status, of any hormones, of any neural activity. So this is what we mean when we say that it is unregulated. Now, the osmolarity of the filtrate in the lumen of the tubule is exactly equal to the osmolarity of the plasma over here in blood. And if you remember, we left off describing the barriers here. So the layers that the solute and water on this side have to go through in order to be reabsorbed. So if we're going from the lumen, we have to go through the apical surface of the epithelial cell. We've got to go through the basolateral surface of the epithelial cell. We've got to go through the peritubular space, which is this gap in between the cell, the tubule, and the capillary. And then eventually we have to go across the endothelial cell that's lining the capillary. But at first, we start off with an isoosmotic situation, meaning that the solute has the exact same solute and water concentration as the plasma. And so normally there will not be any flow unless we set up a gradient that allows water to move, okay? And the way we set that gradient up is by actively transporting sodium across the membrane first, and then that sets up a salt gradient, and we know that if there's a salt gradient, water is going to move from an area of high concentration to an area of low concentration. So that is the whole basis of the reabsorption in the proximal tubule. So let's describe the steps of how that actually happens. So first off, we want to describe the anatomy of the cells here. They're joined by tight junctions. And so we have the luminal surface of the cell, the apical surface of the cell facing the lumen of the tubule, and the basolateral surface of the cell facing the peritubular space. We also want to point out that the apical side has microvilli. We'll talk about this a little bit later on, but the microvilli are basically increasing the surface area, which is allowing for more reabsorption. So this is an adaptation or a modification that facilitates increased reabsorption, especially unregulated reabsorption. We also want to point out that naturally inside of the cells, there is a lower sodium concentration, and that's because of the presence of the sodium-potassium pump on the basolateral surface. So if you remember the sodium-potassium pump, it's pumping 3 sodium out of the cell, 2 potassium into the cell. And so it's going to begin to create the deficit of sodium inside the cell. And because of that deficit of sodium inside the cell, sodium can passively move into the cell according to that solute, that sodium gradient. Okay, so the first thing that happens is sodium is moving from the filtrate into the cell passively because of the gradient that's set up on the basolateral surface by the sodium-potassium pump. Now, when we begin to pump sodium across the basolateral surface and it's moving actively down at the basolateral membrane here, that is attracting chloride from the cell into this space. So now chloride is going to be following sodium and being pumped across the basolateral surface as well. And both of these solutes are going to end up in the capillary, in the peritubular capillary. So basically we have the active transport of sodium across the basolateral membrane, the passive movement of chloride across the basolateral membrane. And so what that creates is a solute gradient where there's more sodium and chloride in the capillary and less sodium and chloride in the filtrate. And so now we have a solute gradient, but now we also have a water gradient, right? So we have high solute concentration here and low solute concentration here, which equates to high water concentration here and a low water concentration there. And so water can passively diffuse according to osmosis across the epithelial cell. Okay, so again, the whole basis of this is that we move solutes to create a gradient, and then water can passively move according to that gradient. And that is how we reabsorb both solutes and water. All right, so sodium is being actively transported, chloride is being passively transported, and then water can follow by osmosis. And that is what's happening in the proximal part of the tubule. Let's go on now to speak about what happens if carriers are maximized, right? So things like glucose, we know, require carriers, right? They're not just going to move across the membrane. They're going to require carriers in order to transport them across the apical and basolateral cell membrane. So this brings us to the transport maximum. So this is the rate of transport when those carriers have been fully saturated. So if you're transporting a solute across the epithelium of this tubule, there's going to become a point where you can no longer transport any of these solutes because you've maxed out all of the carriers that are present on that membrane. And so what happens then is you begin to see that solute coming out in the urine, right? It's no longer being reabsorbed because it can't. And so we begin to see it being excreted in the urine. And that's what we call the renal threshold. So the renal threshold is the plasma concentration at which we begin to see solutes spill over into the urine. So a good example is glucose, right? We should not be seeing glucose in the urine. I kind of mentioned this yesterday because it should be freely filtered across the glomerulus and then 100% reabsorbed in the proximal tubule. So there shouldn't be any glucose appearing in the urine. Now, we know that glucose also requires carriers to be reabsorbed. It's going to require a carrier across the apical surface as well as across the basolateral surface. Across the apical surface, it's being moved according to secondary active transport, and across the basolateral surface, it's being moved according to facilitated diffusion, okay? So let's look at this example for some of the handling of glucose, how the kidneys handle glucose. And let's keep these two ideas in mind of transport maximum and renal threshold. So typically the plasma glucose concentration is about 100 milligrams per deciliter. And so yesterday we calculated the filtered load for glucose. We simply multiplied that 100 milligrams per deciliter, we converted that to 1 milligram per minute, and we multiplied, 1 milligram per milliliter, excuse me, and we multiplied that by our GFR, which is 125, and that gave us a filtered load of 125 milligrams per minute, right? Now, if we talk about the transport maximum for glucose reabsorption, that's 375 milligrams per minute. So we're basically saying here that at 375 milligrams per minute at that filtered load, we can no longer reabsorb glucose and we should start to see glucose spilling into the urine. Now, if we calculate the renal threshold based upon this transport maximum, that gives us a theoretical value of 300 milligrams per deciliter. And I say theoretical because this has not actually been done. Like, this is not what we actually measure in human physiology. This is what physicists and physiologists calculate based upon the number of transporters that are present on the membrane. So theoretically, based upon that transport maximum, we should see glucose spilling into the urine at plasma concentrations of 300 milligrams per deciliter. So that means that if someone has a blood glucose of 300, we should start to see glucose in the urine, theoretically. But in actuality, what clinicians see and what we actually measure in human physiology is that the renal threshold is closer to about 160 to 180. Meaning that when we see patients with glucose levels of 160 to 180, we already begin to see glucose spilling into the urine. And so there's that disconnect between the theoretical renal threshold and the actual renal threshold. And that is not clearly understood, but that we know that there's that difference, right? Why is the glucose spilling into the urine at lower glucose concentrations than we would kind of calculate theoretically? Now, if we calculate the filtered load based upon that actual renal threshold, we see that the filtered load is closer to 225 milligrams per minute, okay? Now, what I want you to kind of take away from all of this is the difference between the renal threshold and the transport maximum. So the transport maximum, and if we go to this graph, this will kind of make a little bit more sense here. So the transport maximum is the rate of glucose movement at which maximum glucose is being reabsorbed and all the transporters are being saturated. Whereas the renal threshold is the plasma concentration of glucose at which we begin to see glucose spilling into the urine. So the difference is the carriers versus the plasma concentration of glucose, okay? And if you look at this graph, we see that the transport maximum here is about 300. This is the rate, 380, I believe. This is the rate at which we see maximum or maximization of all those carriers. Whereas in actuality, our renal threshold is about 160 to 180, whereas the theoretical renal threshold is all the way up here at about 300. Okay, so this is what we calculate, and this is what happens in our actual physiology. All right. Now, the last of those renal exchange processes that we were talking about yesterday is secretion. So remember, let's just remind ourselves, we talked about filtration, we talked about reabsorption, and then secretion is the third mechanism here. And this is where solids are being moved from the peritubular capillaries back into the tubules. And so these are things that the body is trying to get rid of. It's trying to put them back into the tubule so that they can be excreted in the urine. Okay, now the transport mechanisms are for the most part the same, but they're happening in the opposite direction. So the barriers are going to be the same. It's going to be the endothelial cell, the peritubular space, the epithelial cell. Those barriers are going to be the exact same, but the direction of movement is going to be the opposite. Some of the substances that are secreted are potassium. So this is how the body gets rid of excess potassium. Hydrogen ions, this is how the body balances is acid-base balance, right? By getting rid of hydrogen ions via secretion. Choline, creatinine, which are some breakdown products, and then penicillin, which are and other medications that we may be taking, can also be secreted. And this is how the body kind of clears these types of substances. Okay. So I'm going to skip over these checkpoint questions. Again, I want you to either kind of screenshot them or pause here and work on them, but we're going to come back to these at the beginning of our next class, but make sure you try to write down an answer for these questions. Now, what we're going to